Hi everyone, thank you for joining us today. My name is Shema Hassan and today our session will focus on the implementation of social prescribing, highlighting the lessons learned from CLAHRC Northwest Coast, which is now known as ARC Northwest Coast Research Collaborations. I will also be joined by two of my colleagues, Adele Ring and Mark Goodall. So to start off with, I will be talking to you about the Partner Priority Programme, which I will be referring to as the PPP. We will have two presentations of both of our interns that will be talking to you about their social prescribing projects, followed by a presentation by Adele Ring on social prescribing workshop with our different stakeholders. And finally, Mark Goodall will highlight the findings of the online survey. We will finish off by a brief summary and next steps. CLAHRC Northwest Coast Partner Priority Programme. In collaboration with our local partners across the Northwest Coast, the programme was developed in response to their requests for more timely, co-productive evidence to support local services improvement. The PPP provided facilitated academic support and training, including funded internships, enabling partners to conduct project-level evaluation and/or implementation of local service that is relevant to reducing hospital admission, reducing health inequalities, and improving population health and well-being. What was unique about the Partner Priority Programme is that each project, whether it was an implementation or an evaluation project, was a collaboration between academic facilitators, clinicians, commissioners, and members of the public that came together to work to co-produce a project. Each project was supported to disseminate their findings through different avenues, for example, through a CLAHRC Bite, which is a summary of the project, initial findings, and next steps. You can find these CLAHRC Bites on our website. They were also supported to present their findings through oral presentation, poster presentations at local and national conferences. Projects were also supported to write a peer-reviewed paper and publish in high-impact journals. What was also important as part of the PPP program was public involvement and engagement. Each project had at least one or two public advisors that are part of the core project team. They were involved and engaged with the project at different levels. For example, they participated in project steering groups and the wider governance of the CLAHRC Northwest Coast. They contributed toward evaluation design and the implementation strategy plan. They were involved at different stages of the project plan, for example, from the design of the question, to the methodology, to the data collection, to the analysis of the data. Public advisors were also key in the dissemination process. They supported in the writing of CLAHRC Bites, presentation and posters, and also were co-authors on peer-reviewed papers. The PPP also had a health inequality focus. Through the use of health inequality assessment tool, which is known as the HIAT, each project was supported to use this tool to support them identify health inequalities that they can address. This HIAT tool is widely available on our website for everyone to use. So now I will give you a brief overview of the PPP projects using social prescribing. And then we will have a video from Hendry and Suzanne Simpson talking about the social prescribing initiative. The literature describes social prescribing in many ways. However, the main focus for social prescribing, it's about enabling healthcare professionals to refer patients to link workers, or sometimes we call them community connectors. That takes them away from the clinical aspects of care to the social aspects of care. supporting those individuals, finding out what their needs are, their social complex needs, for example, empowering them to find solutions which will improve their health and well-being. Often using services provided by voluntary or community sector. Social prescribing has been encouraged across the UK, and it has shown many benefits through qualitative research. Benefits to the patients or the people who are using the services, but also reducing financial burden on the NHS, and particularly on primary care. CLAHRC North West Coast PPP project had many focuses in terms of social prescribing. We had a great focus on mental health and also overall well-being. But most importantly, we had a great focus on socio-economical needs and social determinants of mental health and overall well-being. So now we are going to hear about two PPP projects from two colleagues based in the Walton Centre. First, we have Claire Hendry from the Lifelink Clinic, which is a multi-agency service providing social and economical advice and support for patients and families at complex rehabilitation inpatient facility.
The local authority, the Brain Charity and the Cheshire and Merseyside Rehabilitation Network collaborated together on an idea known as the Lifelink Clinic. The idea behind the Lifelink Clinic was enable 3 organisations to work together with their knowledge and skills for the benefit of inpatients receiving complex rehabilitation. This would enable a drop-in facility to be piloted at one of our spoke level rehabilitation units. And the idea behind that was to offer a unified approach so patients and their families could drop into the service and be supported with issues such as employment rights, housing, finance, and many other areas such as rent arrears, etc. What we did, we opened up a drop-in service which was operated once weekly, and all patients and families were invited to drop into this service to have support. The Lifelink drop-in clinic was supported each week by a social worker, a welfare and benefits advisor from the Brain Charity, and a rehabilitation coordinator. We used a variety of methods to evaluate the service. For example, pre-implementation, we sent out some questionnaires, and we also carried out some semi-structured interviews with patients, families and staff. Post-implementation, we carried out a number of semi-structured interviews, and users of the service were asked to complete an anonymous questionnaire. Some of the challenges that we've experienced since implementation of the Lifelink Clinic have included cultural, staff time and accessibility of the service. And some of the findings from the evaluation appeared to echo some of the challenges that I've just discussed. For example, during the following thermostatic analysis of the semi-structured interviews post-implementation, we found that a number of staff found that the Lifelink Clinic had a really positive effect in terms of creating more staff time, as the Lifelink Clinic was enabled to support patients and their families with the socio-economic needs, and therefore reducing the impact on clinicians' clinical treatment time, as they were no longer having to find out issues about these for their patients and families. Family members and patients using the service reported that often the service running once weekly and at a certain time, limited their accessibility to access the service. And we also found that when users of the service filled out an anonymous questionnaire, both pre and post consultation at the clinic, we've seen a really positive impact on how patients and families felt that their socio-economic needs were being managed, and in conjunction with this, they self-reported that they felt a lot less stressed and anxious about the socio-economic issues they brought to the clinic. In terms of next steps for the LifeLink project, we are in the process of developing a business plan. We also aim to replicate the service on 2 further identified services within the Cheshire and Merseyside Rehabilitation Network. And we do aim to continue to evaluate the service so we can continue to develop it in line with what our patients and families are telling us.
And now we will hear from Suzanne, who is going to tell us about the pilot project that was developed to support patients living with MND to access activities to enhance their well-being and reduce social isolation.
My name is Suzanne Simpson and I'm employed by the Walton Centre, which is a neurospecialist trust based in Liverpool. I'm an occupational therapist by background and currently employed in a new role funded by the Motor Neurons Disease Association. The aim of the role is to look at how we can prevent social isolation and to improve the well-being of people living with MND. There's approximately 5,000 people living with MND in the UK. It's a complex condition that affects people both physically, cognitively and psychologically. It's a life-shortening condition and there is no cure. People with MND and other long-term conditions have the lowest health-related quality of life of any of the long-term conditions. People with MND have emphasised the importance of psychological support and well-being in order to help them manage their condition. However, health and social care is fragmented, which makes it extremely difficult to negotiate when looking for support. Often, physical needs are not seen as a bigger priority as psychological needs, and this results in unnecessary hospital admissions, GP appointments and the burnout of family carers. The project aimed to identify suitable community activities within the community of Merseyside for people living with MND. Participants were recruited by the multidisciplinary team at the Walton Centre, community therapists and therapists based within the County Council. Patients were then visited by myself and a link worker, and prior to the appointment we asked them to complete an interest checklist, which was then used to initiate discussion. We discussed barriers to participation, and if, for example, it was related to the environment of where the activity might take place or the activity itself, I would provide guidance. However, if it was related to where the local activities were or issues such as debt or finance, the link worker would provide advice. And both would aim to prevent barriers to participation. Participants were followed for up to 6 weeks and were interviewed following the conclusion of their 6-week intervention. A total of 9 people living with MND were recruited to the project, but unfortunately not everybody was able to engage due to the rapidly changing needs. 5 people living with MND, 2 female and 3 male, agreed to participate in the interviews for the evaluation. The 4 link workers involved in the project were also interviewed. The opportunity to engage in activities was important for all the people living with MND. The need to find purpose and to be included was apparent when describing the challenges they'd experienced since diagnosis. Those who were newly diagnosed and had only mild symptomology were able to engage in activities more easily. Participation was seen to help adjustment to giving up work and help to provide purpose. Those with moderate physical difficulties, particularly impaired mobility, found participation more challenging. Participants highlighted barriers such as transport, equipment provision, lack of support to attend activities, and lack of confidence using mobility aids in an outside environment. Link workers highlighted the same barriers and believed increased provision of easily accessible transport and also increased support for the individual to attend activities would help prevent someone not being able to engage. Whilst limited research has explored barriers and enablers of participation for people living with MND, the findings of this implementation project highlight and echo the barriers that people have experienced when trying to access disabled sport. The link workers identified the need for adequately funded community activities, otherwise they would not have anything to refer participants to. I myself felt that 6 weeks was not sufficient in order to provide that support for somebody, and actually individuals with MND require more of a bespoke approach. Social prescribing was designed to meet the needs of people living with long-term conditions. However, this project has highlighted that for people living with MND, they are very likely to experience a number of barriers to participation. Social prescribing pathways should be established to bring together the expertise of health professionals, such as occupational therapists and link workers, in order to reduce the likelihood of people living with MND and other neurological conditions from being unable to access their community. In order to address wider barriers to participation, a whole systems approach is needed, including the consideration of local infrastructure. Further research is needed to determine how best to implement a social prescribing model for people living with MND. This would help prevent health inequalities for this group of people living with a neurological condition. Thank you.
Thank you, Suzanne. Hi everyone, my name's Adele Ring and I'm going to be spending the next few minutes talking about the social prescribing workshop. So as Shane has just described, there were a number of projects within the Partner Priority Programme that either implemented and or evaluated social prescribing initiatives. The purpose of the workshop was to bring together representatives from those projects to share what they had learned and to identify some key learning points that could be shared more widely across the North West Coast region via a planned knowledge exchange event. We had representatives from a broad range of organisations, including public third sector and university organisations, with academics, link workers, service providers, allied health professionals, commissioners and members of the public all coming together to share what they had learned. During group work, attendees were asked to think about different models of social prescribing, to explore what they considered to be the key elements of their programme initiatives, to think about impacts and outcomes of the initiative and how initiatives were evaluated and any particular challenges that they had encountered. Discussions also covered social prescribing more generally. Bullet points from each group session were collated by two of the researchers and a summary document circulated to attendees for their input. So focusing first on models of social prescribing, looking across the projects, two main approaches were identified. The first was a link worker model, which involved an individual link worker working with people to explore issues, needs and interests, and then working with them to identify appropriate, usually non-medical, resources, groups or services and activities that people could access. In some instances, the link worker model extended to a buddy system where a community champion might initially attend activities with people until they had built up their confidence to attend on their own. The second model involved the setting up of a resource or service hub. Hubs brought together a range of expertise and support to provide a more holistic and joined-up type of support. Some hubs had a member of staff that acted as a link worker. When we started thinking about what was important for social prescribing, there appeared to be three overarching concepts that cut across our discussions of implementation, evaluation and sustainability of social prescribing services. These concepts were operationalising a personalised approach, whole systems working, and public engagement and involvement, with financial support also being central to social prescribing activities. So now I'm just going to say a bit about each of these three concepts and why each was important. The first concept was that of operationalising a personalised approach. A personalised approach has always been central to the ethos of social prescribing. What we were able to understand better from the social prescribing workshop was how a personalised approach can be operationalised in practice and why this approach was important. Focusing on implementation, central to providing a personalised approach was the link worker's knowledge of local resources, services and groups. In order to advise and direct people to appropriate services, link workers needed to have a detailed understanding of local resources, with there being a sense of knowing those services. Important in knowing services was being able to build relationships with local groups, organisations and services. This helped to facilitate flows of information between the link worker and the service or group. This two-way communication between the link worker and the services and organisations was considered an important area for pathway development. The second component of the personalised approach was active listening, to ensure that a person's needs and interests were fully explored, which was important in determining the appropriateness of particular groups and services and activities, and therefore in offering a personalised service. Finally, the ability of services to be able to adapt in response to changing local needs was considered important in ensuring appropriate services were available. The second concept that was important for implementing social prescribing was that of whole systems working. Long-standing relationships were important for developing collaborative working and delivering services, including resource and service hubs. Communication processes, in particular two-way communication between link workers and health professionals and services involved in the referral pathway, was considered important in implementing social prescribing. As such, the referral pathway, rather than being a one-way process, would be more of a spiral that would be beneficial both for those accessing the services and those involved in developing and delivering them. Finally, hub-based social prescribing models, where some services were co-located, provide an environment that facilitated the provision of personalised and holistic advice and support. The third concept that was important for implementing social prescribing was public engagement and involvement. All projects worked with service users in implementing and evaluating social prescribing initiatives. Members of the public and service users were involved in shaping service development, helping to ensure that services were appropriate and responsive to local needs. The role of the public, service users and volunteers was also important in supporting others to engage with local resources and groups, with an emphasis on the importance of trusting relationships in supporting people to engage. Service users and members of the public were also able to bring a health equity lens into the development and evaluation of social prescribing services. Whilst PPP projects had implemented and or evaluated social prescribing initiatives, there were some identified challenges both in implementing these initiatives as well as thinking about implementing social prescribing more generally. Some of the challenges related to specific patient populations, whilst others were more generic. A more generic issue was that of navigating the local system, both from a health professional as signposter perspective and for people seeking to access local resources. The issue of multiple directories was highlighted. Health professionals as signposters have an important role in engaging people with local resources and services, and as such, it was identified as important that they had appropriate information and knowledge about local services in order to be able to signpost people to the most appropriate service. It was noted that access to services could be constrained by the referral pathway, depending on who was able to refer people into the social prescribing service. Understanding the role of different health professionals and those involved in the referral pathway was also important. Given that it was noted previously that people's perceptions about different services could be barriers to engagement, how people were engaged with local resources was important. Here, other service users and volunteers were thought to have an important role to play. While social prescribing services were implemented through collaboration between agencies and services within local systems, there were some challenges to this. These included changes in staffing, bringing together different care models, and integrating new and pre-existing services and processes. Perhaps not surprisingly, capacity was also identified as a particular challenge to implementing social prescribing services more generally. Capacity included the availability of funding to develop local resources, including group services and activities, retention of staff and volunteers, the increasing complexity of referrals and the potential, therefore, for the need for additional training and support that might be required in relation to this, and finally, the various practical and organisational constraints on delivering social prescribing services. So now I'm going to spend a few minutes focusing on the evaluation of social prescribing initiatives and services. Across the SP projects, both quantitative and qualitative methods were used to evaluate services. Several projects collected pre- and post-intervention data. Some used validated measures such as the WEMWEBs, whilst others had developed bespoke measures, for example goal-based measures, and some used process measures, collecting information, for example, about number of calls to a particular service. Several projects used pre-implementation surveys to identify issues, needs and current experiences. Some projects used a combination of quantitative and qualitative measures, for example collecting process data and also undertaking interviews with clients and or service staff to explore perceptions and experiences of services. Looking now at the types of impact that projects explored, there were three main categories of impact: psychological, social and health service use. Most projects evaluated the psychological impact of their service using either validated measures of well-being, bespoke measures, or they explored changes in well-being through qualitative inquiry. Several focused on social impacts, including reduction in social isolation and loneliness, and several recorded healthcare usage and process data. A broad range of outcomes were measured, including wellness scores, loneliness scores, service user and staff experience, did not attend rates, service costs, service usage and referral routes, amongst others. There were a number of challenges in evaluating social prescribing services. Demonstrating statistically significant change was problematic due to limitations of data, including small sample sizes. Challenges to evaluation could largely be categorised as issues of measurement, issues around getting the data, and delivering outcomes. Issues of measurement included finding the right measure that was appropriate in the context of the particular service and the client or patient group. Whilst validated measures are increasingly being advocated, finding appropriate measures was not straightforward, and some services had also developed bespoke measures. A second issue was getting the data. There was a challenge of accessing data for evaluation, with data governance constraints making it difficult for relevant information to be shared. Thinking more generally about future comparisons across services, variable data collection across services could preclude such comparison, and there was also the issue of missing data. Delivering outcomes. In terms of delivering outcomes, there was the question of what outcomes are important to whom, with the potential for a mismatch between what outcomes might be important to, for example, service users, clinicians, managers, commissioners or researchers. There was also the question of how to capture more long-term incremental change that was not captured where evaluation timelines were short. In this context, the importance of capturing change and impact that was not amendable to quantification was emphasised. Two further challenges to evaluation were also those of time and costs. The time it takes to undertake an evaluation in the context of limited staff resources and timeframes for evaluation, and the funding resources required to undertake large-scale cost-benefit analysis. So looking finally at the long-term sustainability of social prescribing services, there were a number of important elements. The first was an emphasis on services that were being developed with service users and members of the public, and the importance of involving members of the public and service users in commissioning decisions. The second element was capacity building, including funding for training and support for link workers and volunteers, and funding to support the development of local groups and services, particularly in the context of the anticipated increasing demand and complexity of social prescribing referrals. The adaptability of services to meet changing local needs was also considered important. And finally, thinking about evaluation, it was noted that it was important to evaluate the impact of increasing demand on social prescribing service providers. So now I'm going to hand over to Mark Goodall. Thank you.
Thank you, Adele. Hello, my name is Mark Goodall and I'm going to present some data from our online survey. We carried out a baseline survey on social prescribing in the North West Coast region. Our survey aimed to capture a snapshot of social prescribing projects' activities. We plan to repeat this survey at 6 and 12-month time points. Our online survey was conducted in February and March of this year. We initially invited partners within the ARC North West Coast and those we knew to be involved in social prescribing to complete the survey. In addition, we asked this initial group to share the survey web link with colleagues involved in social prescribing. There were 49 respondents, of which 35 were actively involved in social prescribing. This group described 50 projects. This data is presented today. The actively involved group included link workers, managers and commissioners. The remaining 15 respondents, which was made up of public advisors, supporters and researchers, were aware of but not actively involved in specific projects. Most of the projects, 47, were working in urban areas, but they also covered semi-urban and rural areas as well. The map shows the spread of these projects throughout the North West Coast region. The pie chart shows that half of the projects have been running for less than 12 months. Respondents identified many different aims for these projects. A selection of these aims is shown here. Some were very specifically topic focused, for example, reducing alcohol-related self-harm, and some projects were more generic in their aims, for example, improving health and well-being. Others focused on implementation of the service, for example, delivering community activities. A variety of models were identified. Overall, social prescribing aims to understand what matters to the person and to link them with appropriate support. Whichever name is used for this role, each is a non-clinically trained staff member that works with a person who has been referred to them. It offers a service that is based on an equal relationship between the person receiving support and themselves as link workers. There are multiple ways to deliver this service. Some link workers acted as a signposting service, in our case 76% of these projects, as opposed to those 50% of the projects spending consultation time with a person. In addition, link workers can accompany the person on their journey through different organisations, both within and outside the NHS. This graph shows that most of the projects focused on serving working adults and those of retirement age. A few projects did target people across the whole life course. As I mentioned earlier, a link worker spends time with the referred person, working out how to support their needs and their goals. National guidance does not suggest a specific time frame for this. As you can see, in these projects there are a variety of time frames from initial consultation through to follow-up, and some projects suggesting that this should be for as long as each person needs it. Not explored in this survey is the reason for these time choices, whether this reflects capacity within different areas or time allocated is condition specific. Many ways of delivering the projects were described. A link worker aims to motivate and support individuals to achieve the changes that they want, and may use activities as well as specific motivation techniques to help with these goals. The projects describe multiple routes for an individual to access social prescribing and support activities. The main route was through their GP, but many services are also allowing self-referral to their link workers. The table highlights the other routes of access. As mentioned in our workshop presentation, having good public involvement is an important part of implementing a new service. We found that 66% of these projects actively involved members of the public. The graph shows that over 50% of these projects involved public advisors in raising awareness, evaluation and co-creation, amongst other areas. In the survey, we asked the respondents what they thought to be key elements for a successful project. They identified the following areas as most important: securing adequate and sustainable funding, getting the program set up and running, and engaging and motivating people to engage in services and activities. There were other areas that respondents thought important. These resonate with what was said in the workshop. For example, working on building and maintaining relationships, choosing a target or generic social prescribing model, and getting health service buy-in to voluntary service opportunities. The figure shows the many challenges identified by respondents, with secure funding and sustainability mentioned most. There were also challenges around understanding the social prescribing offer, diversity within conditions or communities, and having the capacity to deliver activities. As I've mentioned in previous slides, having sustainable funding was both a key element to success and a challenge. Within our survey, we asked how projects were funded, with 52% having been commissioned. Funding time varied. As you can see in the chart, 36% of the projects were funded for less than 2 years, and 30% had no specific time limits. We found that 29 projects were undertaking an evaluation of their work. The table shows they are planning to use a variety of methods, from using validated questionnaires and measures, using focus groups or interviews, case studies, or through their own data reporting tools. There were several challenges identified to evaluating these projects. However, key ones were deciding what outcomes to measure or data to collect, capturing or accessing the data you need, and finding time for the evaluation.
Thank you, everyone. Now, to summarize our session, I will highlight key learning points. So, as described throughout this session, social prescribing has many moving points. However, how these all come together can sometimes be challenging. But most important, when implementing social prescribing, sustainability is key to help continue that support and capacity building. Public involvement is so important to develop and bring that public perspective and that health inequality lens toward the development and the evaluation of services. Also building relationships and co-production across the system, creating those networks to support those third sector and that link between primary care and community services. And finally, evidence-based implementation of social prescribing. This includes carrying out robust evaluations to support the development of an implementation strategy that will enhance the delivery of social prescribing. So the next step for us is that we're hoping to bring people together who are interested in social prescribing across the Northwest in an ARC Northwest Coast Knowledge Exchange event that will explore certain questions around implementation and evaluation of social prescribing. This will include questions such as, are we asking the right question? How do we measure the effectiveness of social prescribing? How to coordinate social prescribing within the community, and how to develop communications pathways, and how to support link workers within their role and also volunteers. The date of this event will be confirmed in the near future. However, to find out more, please contact Catherine Abba on the email provided below. And I would finally like to thank everyone for joining us in this session.